I'd like to turn to Anne Marie Schneider, who will be introducing our next speaker.
Thank you, Esther. And I want to make that a really big thank you to Esther Anaga and Laura Bates. We've been working together for, it's been almost 10 years. And they have produced a number of briefing reports. You have a list of those in your packet. I think I rushed up here. And they're really very helpful. They're very applied. And they all apply to Michigan, the state of Michigan. What this can be used for, these kinds of briefings, are a wonderful communication for your constituents, people who call and have questions on these issues. They can pull them offline. They're not heavy duty. You can pop them in the mail, and they're really very, very informative to people who are concerned about this, maybe for their family or just personal interest, but also a professional interest. So that's a resource for you that you may have not seen before. That's ready and available. So there you go. Thank you again, Esther and Laura, for, I think, just your tremendous passion for public policy in the area of families. And I also want to commend the support of Dean Karen Wampler for really taking a leadership role and looking at policy in a way that is, again, focused on the family. I think this is a new expertise that's come about in Michigan, and I want to encourage you to continue that. On behalf of the Institute for Public Policy and Social Research, thank you for being here today. Dr. Post, your presentation, every slide had something so profound in it and had just profound implications for public policy in Michigan, so thank you for that. It is really my pleasure to introduce JverDier. I'm so excited about his being here, and am thrilled to have his expertise in Michigan. He's not a stranger to Michigan. He knows this pretty well. He'll be jogging the trail after lunch today. So I was impressed that he actually remembers the Riverfront Trail. You'll probably see our legislators. Maybe you guys could run along and talk about these most important issues. Jim's the senior fellow at Mathematica Policy Research, Inc. in Washington, D.C., where his work focuses on Medicaid, state health policy, and Medicare. He's also a senior program consultant for the Center for Healthcare Strategies, another excellent resource for you. This is a foundation-funded organization that helps states develop, purchase, and improve managed healthcare programs. Jim's a visiting lecturer at the Woodrow Wilson School at Princeton University. He's also taught courses there on state health policy since 1998. He was the Indiana State Medicaid Director from 91 to 97. After paying his dues in Indiana is when he went to Washington, D.C. Before that, he was the Deputy Director of the Michigan Department of Management and Budget. So he probably sees a few familiar faces in the fiscal agencies here. Jim has taught public management and policy analysis at the Kennedy School of Government at Harvard. And in the early 80s, he headed the tax analysis division of the Congressional Budget Office. At the onset of his career, he served 7 years as a legislative assistant in the U.S. House of Representatives and the U.S. Senate. He's a graduate of Dartmouth College and Harvard Law School. So again, come on up here, hurry. We want to hear everything.
Thank you, Anne Marie, for that very kind introduction. And thanks very much to Esther and Laura for all of their help. Mike Head from the Department of Community Health and others who were very helpful as well. And thank you all very much for coming. And a correspondingly lower share of expenditures for the elderly in Medicaid. That unknown number there, fairly large in Michigan, I think is largely accounted for by people in managed care and and their expenditures are sometimes a little difficult to disentangle. Looking at the payments per enrollee in Michigan versus the rest of the country, Michigan is consistently lower than the national average in all of these categories in terms of spending per person. So that's gives you some perspective on that. Then this slide gives you a little sense of how the distribution of long-term care expenditures varies between Michigan and the rest of the country. As you see there, Michigan tends to spend a little bit more on institutional services, nursing facilities, and ICFSMR, intermediate care facilities for the mentally retarded, and other institutional services, and a somewhat lower percentage on community-based services. And in terms of spending on community-based services, Michigan ranked in 2006 36th nationally. This looks at spending in a somewhat different way. This is not spending per person, but rather it's spending for those categories of services divided over the entire state's population, or the entire U.S. population for that number. So it's in a sense a measure of the burden on taxpayers of those expenditures for different kinds of services. And you'll see there again that the Michigan spending per capita is pretty consistently lower than the national average. You can maybe see that a little better in this nice graph that Tiffany helped me put together, which shows essentially the same numbers but in graphical form. And again, you'll see there that the spending in Michigan measured in this way for most services tends to be lower than the national average. MRDD is mentally retarded, developmentally disabled. That's the major waiver in Michigan and most other states, but there's also a waiver for people who are aged or disabled in Michigan and in other states. And you see there personal care as well. The trends in personal care expenditures in Michigan I thought were kind of interesting because there hasn't been the same kind of growth over this period of time in those expenditures that have occurred in other states. Because these expenditures, because it's a fairly desirable service to have personal care assistance in your home. So in order to keep expenditures from growing fairly rapidly, most states do need to limit it in some fashion, and Michigan has apparently, from these data, been able to do that. Looking a little bit more closely at nursing facility utilization, you see there that the occupancy rate in Michigan is a bit higher than the national average, so there's less unused capacity in nursing facilities, if you will. A somewhat smaller percentage of the Michigan over 65 population is in nursing facilities than in the national average. So looking at ways of reducing nursing facility use through increased use of various kinds of community care, and that is reduction of institutional use is a major goal of most kinds of home and community-based service waiver programs, personal care programs, home health care. That's a major goal of those programs, in addition to the benefit to the individuals of being able to get care in a setting that most people find preferable, if possible, to institutional care. But an important thing to keep in mind is that unless community care services are limited primarily to those who would otherwise go into a nursing home, not necessarily who meet the level of care standards for admission to a nursing home, but who would actually go into a nursing home if they didn't have that community alternative available, unless the community programs can be targeted in that way, they tend not to increase use of nursing facility services and nursing facility expenditures. They tend to add on to the nursing facility expenditures, and this is commonly called the woodwork effect, the notion being that people come out of the woodwork to obtain access to a desirable service when they would not normally want to be in a nursing facility. So that access to community services must in some fashion be fairly tightly managed to achieve those kinds of net savings, and that includes limits on eligibility, services used, some combination thereof. So looking at managed long-term care, which is a way of managing community services and the relationship between those services and nursing facility services. The basic notion is that managed care puts contractors of some sort, and these can be either public or private, they can be for-profit or not-for-profit, at risk for a defined package of Medicaid services. The contractors are paid a capitated amount, a fixed amount per enrollee, much as in your managed care program for acute care services that's pretty widespread in Michigan. They receive a fixed amount per member per month, and if the needed services cost less than those payments, the contractor keeps the difference, makes a profit. If they cost more, the contractor incurs a loss. And there are a lot of different variants of this kind of risk-sharing approach. Commonly, when new programs are started, the state might bear